Bismillahirrahmanirrahim. The quote of the day is from the Holy Quran, Surah Shuara, verse 83. It is the dua of Hazrat Ibrahim alayhi salam. Rabbi habli hukman wa alhiqni bis-salihin. ऐ मेरे रब मुझको हिकमत अता फरमा और मुझको नेक लोगों में शामिल फरमा. So the topic of today is human papilloma virus. I'm your host Dr. Fouzia Iqbal, rotational PGR, FCPS Medical Oncology from New Hospital Lahore under supervision of Professor Dr. Saira Afzal. The list of contents that we will cover is overview, virus structure, HPV types, clinical presentation, associated clinical syndrome, associated carcinomas, pathogenesis, timeline, transmission, prevention, vaccination, screening, diagnosis, management, and MCQs at the end. So, a bit of overview. HPV is a group of small non-enveloped double-stranded DNA viruses encased in a protein capsid. It infects epithelial tissue of the skin and mucous membrane. It is one of the most common sexually transmitted infections worldwide, increased incidence in the developing countries. If you look at the global trends, it involves 80% sexually active people acquire HPV in their lifetime. The prevalence is 11 to 20% in females, genital HPV infection, and causes 95% of cervical cancers, mainly by high risk type 16 and 18. And the annual burden is 660 cervical cancer cases per year and 350,000 deaths per year. This is the statistics from the US. If we see in the region of Pakistan, cervical cancer is the third most common cancer in women. 5,000 new cases per year and 3,000 deaths per year. HPV is detected in 70 to 95% of the cervical cancers, mainly the dominant types, and the key issues are due to low screen coverage, low HPV vaccination uptake, and late presentation, which leads to high mortality. If we see the viral structure, it constitutes the outer protein coat capsid made up of 72 capsomeres. The virus capsid protects the viral genome. It gives it icosahedral shape. It helps attachment and entry into host cells made up of two key structural proteins, L1, L2. L1 is the major protein, highly immunogenic and target of vaccine. L2 is the minor protein, assists in packaging of DNA and entry into cells. This is a diagram of the capsid and the viral genome. If we look at the viral genome, it constitutes of three regions. The early region, which has E genes, make up 50% of the genome, which encodes proteins required for viral replication and host interaction. The proteins with their function are E1 causes viral DNA replication, E2 transcription regulation and viral genome maintenance, E4 disrupts the cytoskeleton and help virion release, E5 enhances growth signals and immune evasion, E6 and E7 play a major role in oncogenesis, E6 inhibits P53 and E7 inactivates the RB tumor suppressor gene. The second part of the viral genome is the late region, the L genes, which cause capsid formation. They encode structural proteins that is L1 and L2 expressed in differentiated epithelial cells and are required for viral assembly and packaging. The third region is the long control region or the upstream regulatory region. Non-coding regulatory region constitutes 10% and contains origin of replication and promoters and enhancers and transcription factor binding sites, and they control the viral gene expression and replication timing. Now the different HV types, more than 200 genotypes, they are classified based on the oncogenic potential and classified into low risk, intermediate risk, high risk. Low risk is HPV 6, 11, 42, 43, 44. Intermediate risk is HPV 33, 35, 39, 52, 58. High risk is HPV 16, 18, 31, 45. Clinical presentation, most of the cases 70 to 90% are asymptomatic, no visible lesions detected only on screening, and then they present as cutaneous warts. Low risk HPV types 1 to 4 cause it, and among it is common warts. Verruca vulgaris, plantarwarts, Verruca plantaris, flatwarts, Verruca plana, and they present as papules, hyperkeratotic lesions on hands, feet, and face. Then they also present as anogenital warts known as condyloma acuminata caused by the low-risk strains HPV 6 and 11, and they occur in 90% of the genital wart cases. They present as soft cauliflower-like lesions on vulva, cervix, penis, perineum, and perianal region, and are prevalent in 1 to 2% sexually active people. Then HPV associated symptoms also appear as cervical precancerous lesions. They are caused by high risk strains 16, 18, 31, 33, 35, and are divided into low grade lesions, that is CIN1, and high grade lesions CIN2 and CIN3. The low grade lesions 60% regress spontaneously, and the high grade lesions, if untreated, they progress to the invasive carcinoma. Then cervical carcinoma presentation can also occur. 99% of the cases are associated with persistent high-risk HPV infection, that is 16 and 18 strains, and they present as postcoital bleeding, intermenstrual bleeding, foul smelling, vaginal discharge, and pelvic pain, which occurs in the later stage. Then, cervical carcinoma is the most common HPV associated carcinoma, but other malignancies are also seen. Among them are oropharyngeal carcinoma, 70% of the cases are squamous cell carcinoma, and anal cell carcinoma, then vulvar and vaginal carcinoma, and penile carcinoma. Now, this is a list of associated clinical syndromes that we see with different HPV strains, and I have given the name of the strains as well. Now, if we see at the HPV associated cancers in females, the distribution is given. 48% are cervical carcinomas, 17% are anal, 14% are oropharyngeal, 16% are vulvar, and 3.94% are vaginal. Then, if we look at the age distribution, there is increased incidence of precancerous lesions in the years 25 to 34 years. The peak incidence of cervical cancer is 45 to 54 years. The median age is 50 years. If we see the pattern of HPV associated carcinomas in males, it is as such, in males, oropharyngeal carcinoma constitute 81%, 11% are anal carcinomas, and 6% are penile carcinomas. Then, if we come up to pathogenesis, it includes the following steps: entry into the host cells, viral infection and replication, role of early proteins that cause oncogenic mechanisms, persistence versus clearance, and progression to precancerous and cancerous lesions. So, first of all, there is entry of virus into host cells and the initial infection, which is transient. It enters through microabrasions in skin or mucosa, infects the basal epithelial cells, and targets the stratified squamous epithelial cells of cervix and anogenital region. Then the next step is viral replication. The virus DNA initially remains episomal, that is non-integrated in the early transient infections. The early genes E1 and E2, they control viral replication and transcription. The virus replicates as epithelial cells differentiate and it moves upwards. The late genes L1, L2 expressed in superficial layers for virion assembly, and virus is released with desequination. There is no cell lysis. Then the most important mechanism are the oncogenic mechanisms, which are seen in high risk HPV strains like 16 and 18. What they do is they integrate into the host DNA cells. There is loss of E2 regulation, which leads to overexpression of E6 and E7. Now these proteins, E6 binds and degrades P53, leading to reduced apoptosis, whereas E7 inactivates the RB protein and causes uncontrolled cell cycle progression. So, as a result of these mechanisms, there is increased cell proliferation, decreased apoptosis, and genomic instability leading to dysplasia and mutations, ultimately causing cancer. Now, most of the infections they are cleared, and the mechanisms that are involved in clearance are immune mediated clearance. Then there is role of innate immunity and humoral immunity. So the time course of clearance is most infections they clear within 6 to 24 months. The clearance is faster in younger immunocompetent individuals. Persistent infection occurs after when immune response is inadequate. Now the factors affecting the clearance are immunosuppression, most commonly HIV infection, high risk HPV strain 16 and 18, smoking, co-infections, and host genetic factors. Now, ultimately, if the virus is not cleared, it leads to persistent HPV PV infection, and the persistent infection initially causes precancerous lesions, low grade and high grade lesions, and if they are untreated, they will progress into invasive cervical carcinoma. So, if we look at the natural history of the HPV, the timeline is that first of all, there is exposure and transmission via sexual contact, which leads to initial infection. The viral infects the basal epithelial cells through microabrasions. Then, the early infection phase, which lasts around 3 months, in which there is viral replication, and it is mostly asymptomatic or it may present as subclinical infection. Then there is transient phase which lasts 3 to 24 months, and 70% of it is cleared by 1 year and 90% is cleared by 2 years. So after that, there is the phase of persistent infection which lasts for more than 2 years, and 10 to 20% of the cases the infections it persists, and most common with high risk strains 16 and 18, and it is a critical step towards disease progression. The precancerous changes then come development of low grade and high grade precancerous lesions which take around 2 to 10 years, and if they are remain untreated they will further progress into invasive cancer which takes 10 to 20 years to develop, and progression from precancerous lesions to invasive carcinoma, it occurs in small proportion of the persistent cases, and mostly it is linked to HPV strain 16 and 18. Now this is a curve showing the latency period of the HPV strain. So if the HPV exposure is at 15 years, initially there is transient infection, but it will ultimately be mostly it will be cleared, but if untreated and uncleared, it will result in persistent infection. So by the age of 30 years, the patients mostly develop the precancerous lesions, and then the cancer develops after 35 years to up to 45 years. This is again a slide of the natural history. Then, if we look at the transmission modes, most common is sexual transmission. It constitutes 90 to 95%. Then, a few also transmitted by non-penetrative skin-to-skin contact, which constitutes 5 to 10%. Then comes the vertical transmission, although the rate is low, less than 2%, but it can occur during vaginal delivery, and it can lead to juvenile respiratory papillomatosis. Then very rare, but still it has been reported fomite transmission, which is less than 1%. Factors affecting the transmission are multiple partners, early age of sexual activity, immunosuppression, and lack of vaccination. Now, if we come to prevention, it may be divided into primary prevention includes vaccination and safe sexual practices, secondary prevention, screening, tertiary prevention, disease management. If we look at the HPV vaccine, there are different types. There is bivalent vaccine, there is tetravalent vaccine, and nonavalent vaccine. The bivalent vaccine, the brands are Cervarix and Sicolin. It covers HPV strain 16 and 18, and the protection is around 70%, and it protects against cervical cancer mainly, and it is used in public health programs. Then is the tetravalent vaccine, which is comes by the name of Gardasil. It covers the four strains HPV 6, 11, 16, 18, and it covers the high risk as well as the low risk strains, and it protects against cervical cancer, anal cancer, and genital warts. And the novel HPV vaccine, that is nonavalent Gardasil 9, it covers 9 HPV types, high risk and low risk, and the protection is broader, around 90%, and it prevents cervical cancer, anal cancer, oropharyngeal cancer, vulvar and vaginal cancers, and genital warts. Now, here is a comparison of the bivalent and the nonavalent vaccine. And as it is seen that the Gardasil, although it has broader coverage around 90%, and it also covers the low risk strains as well, but the coverage of bivalent vaccine is also good, and that's it is affordable, and that's why it is used in EPI programs in most lower middle income countries. So, if we look at the mechanism of HPV vaccine, it is made up of virus-like particles from L1 capsid protein of human papilloma virus. It is non-live, non-infectious, and it is taken up by the antigen-presenting cells, processed and presented to MHC class 2, activates the CD4 cells, stimulate B cells, and ultimately IgG antibodies are formed. These IgG antibodies, they form the memory B cells. So once the virus is exposed, these antibodies bind to the virus and they block the viral entry, and they provide long lasting immunity. So the schedule is usually around 9 to 14 years. Two doses are given 6 months apart, but it can be given in 15 years and above or immunocompromised. But three doses are given at 0, 2, and 6 months. The target population is both girls and boys, ideally before the sexual debut, but it can given in any age during the reproductive cycle. But with increasing age, the benefit is reduced, and it is effective against protecting the cervical precancerous lesions, cervical cancer, anal cancer, and genital warts. The WHO target for HPV vaccine by 2030 is 90% girls by the age of 15 should be vaccinated, 70% women should be screened by the age of at the age of 35 and 45, and 90% with cervical disease should be treated. So, in primary prevention, there is a role of safe sexual practices as well, that is, barrier protection, limiting number of sexual partners, mutual monogamy, delayed sexual debut, sexual health education and awareness, and regular STI. Although the physical protection, it gives only coverage by 60-70%. Now, the screening methods are the main objective of screening is to detect the high risk strains that will cause precancerous or cancerous lesions, and identifying these women and referring them for colposcopy. The target population are the cervix bearing individuals aged 21 to 65 years, and special groups like HIV positive women are also included. Screening modalities are primary HPV DNA testing, which is highly sensitive, cytology, pap smear, then co-testing is also done, and HPV mRNA testing is also done, that for the proteins E6, E7, and this is the most specific. Then the screening algorithm is such that by age 21 to 29, the screening is started with cytology alone. If the screening is negative, it is repeated every 3 years, and if the screening is positive, then pap smear is done, and if cytology is positive, then the patients are referred for colposcopy. So the screening is also done in HIV positive women, and in these population, the age of screening is early, and the screening is more frequent. Then this is the algorithm for screening. The diagnostic tests that are used for screening of HPV are HPV DNA testing, which is the primary test. Then HPV genotyping is also used. Then HPV mRNA test is also used and cytology is used. Then, if cytology is positive, these patients are referred for colposcopy, and if there is abnormal finding on colposcopy, biopsy is taken. And histopathology is gold standard for precancerous and cancerous lesions. And immune histochemistry also helps in diagnosis and prognosis, that is P16 and Ki-67. If we look at the management, there is no antiviral cure, so managing the conditions is done. For asymptomatic patient, no treatment. Then repeat testing is done upon 12 months. Then for genital warts, if it is low risk, then only observation is done. But if it is high risk, microwave mode can be applied, and if not treated with that, cryotherapy or electrocautery or excision or laser can be done. Then pre-cancerous lesions, low-grade lesions, observation is done, but with high-grade lesions, we can do the loop excision or conization. And for invasive cervical carcinoma, for early stage, surgery is done, and for later stages, radiotherapy, chemotherapy, or targeted therapies are given. Now let's come to the MCQ part. Which of the following statements best reflect the global distribution of HPV related cervical cancer burden? Highest incidence is seen in high income countries due to better detection. B. Majority of cervical cancer cases occur in low and middle income countries due to limited screening and vaccination. C. HPV prevalence is uniform across all geographic regions. D. Mortality from cervical cancer is highest in regions with organized screening programs. E. HPV 16-18 precancerous prevalence is lower in developing countries as compared to developed countries. So the correct answer is B. Number 2, human papilloma virus is best described as enveloped RNA virus, non-enveloped DNA, double-stranded DNA virus with icosahedral capsid, enveloped single-stranded DNA virus, non-enveloped RNA virus, or retrovirus. So the answer is B. Number 3, the oncogenic effect of HPV E6 protein is mainly by A. Activation of RB protein, B. Degradation of P53, tumor suppression, C. Activation of telomerase, D. Inhibition of cyclin D, E. DNA repair enhancement. So the answer is B. Number 4, which HPV type is most commonly associated with adenocarcinoma? HPV 6, 11, 16, 18, or 42? So the right answer is D, HPV 18, whereas HPV 16 is most commonly associated with squamous cell carcinoma. Number 5, which lesion is most strongly associated with high risk HPV infection? A. Condyloma acuminatum, B. Verruca vulgaris, C. Bowen disease, D. Plantar wart, E. Common wart. So the right answer is C. Bowen disease. Number 6, HPV related oropharyngeal cancer are most commonly linked to A. HPV 6, B. HPV 11, C. HPV 16, D. HPV 18, E. HPV 33. So the right answer is C. HPV 16. Number 7, a 32-year-old woman in high risk HPV positive non 16-18 with negative intralesional or malignant cytology. What is the next step? A. Immediate colposcopy. B. Repeat HPV testing in 12 months. C. Repeat after 5 years. D. Start treatment. E. Perform biopsy immediately. So the answer is B. Repeat HPV testing in 12 months. Number 8, which test is more specific for detecting transforming HPV infections? HPV DNA PCR, B. Pap smear, C. HPV mRNA assay, colposcopy or hybrid capture assay? The answer is C. HPV mRNA assay. Number 9, which statement best explains the mechanism of HPV vaccine? A. Induces cytotoxic T cell response against infected T cells. Number B. Contain live attenuated virus. Number C. Use virus-like particles alveolar protein to induce neutralizing antibodies. D. Integrate into host genome. E directly inhibit E6, E7 proteins. So the correct answer is C. Number 10, which of the following is the strongest predictor for HPV infection to high grade precancerous lesion? Number A, age less than 25 years. B, infection with low risk HPV type. C, persistent infection with high risk HPV type. D, single transient infection. E, male partner status. So the correct answer is C, persistent infection. This is the key to all the answers. This is the YouTube channel on which it will be uploaded, and with that we come to end of our presentation. Thank you.